A very good evening, all of you. So, hello and welcome to this pediatrics recall session for the INI-CET exam that happened yesterday. So, please confirm if I'm audible and if my screen is visible so that we can start. Can someone please confirm if I'm audible and if my screen is visible? So, you must be having, a flood of recall sessions since yesterday. So, it is very important that whenever you give an exam, you come back and, recollect the questions and you analyze the options and once and for all know what should be the correct answers and the best way to approach the question. Okay. So, hopefully, you might not need to appear for a similar exam again. You should be able to clear it, but if at all you're able, you have to appear in some other exam subsequently which is based on a similar pattern, like if you want to appear for your super specialities and other things. So you will definitely need all that grasp over the subject and the technique again. So let us do a quick recall of the pediatrics questions that came in this INI-CET November session. Can someone please confirm if my screen is visible and if I'm audible so that we can start? Not able to see your messages. Let me just wait for a quick confirmation. Can someone please confirm if my screen is visible and I'm audible so that we can start? Yes. So before we start this session, a quick disclaimer that this is a purely recall based session based on the options and the questions that we've got from you students. So we will try to come to as close as the question that was asked to in this INI-CET exam. So the exact language of the question and some of the options might be different. So wherever you feel that there is such a thing, then you are free to please message us on our social media handles so that we can come up with the exact questions, a refined version of this subsequently for you, okay, in the PrepLadder app. So let us start with the pediatrics questions in this INI-CET session. So the first question that we'll be discussing, which of the following is not included in NADA's criteria? So many times in our main videos, in the rapid revision videos, we have, discussed about NADA's criteria. We all know that NADA's criteria is basically used for assessment of presence of congenital heart disease, okay? Whether a congenital heart disease is present or not, right? And time and again, so many times in our, rapid revision and in our revision videos, we've discussed about NADA's criteria. So NADA's criteria, we all know, have got some major criteria, some minor criteria. Major criteria include any diastolic murmur, systolic murmur greater than equal to grade 3, any evidence of congestive heart failure or cyanosis. And the minor criteria include abnormal BP, chest x-ray, systolic murmur less than grade 3, abnormal second heart sound and abnormal finding on ECG, right? So going back to the question, so which of the following is not included in NADA's criteria? Good evening, Dr. Sajad. So which of the following is not included in NADA's criteria? So we know congesto, don't miss the word not, okay, and don't jump and answer the first question. I hope you've not done that. I'm sure all of you must have answered this question correctly. So congestive heart failure is a component of NADA's criteria. Diastolic murmur is. Elevated troponin is not a criteria. Abnormal x-rays. So the best answer to this question is C, elevated troponin, okay, right? So the next question, which of the following? So there were two questions from severe acute malnutrition this time, and we all know again in rapid revision, in LRR, everywhere we've discussed SAM time and again because it is such an important topic, and almost every exam you get one or more questions from here. So which of the following is not included in the diagnostic criteria for severe acute malnutrition? So we all know the diagnostic criteria for severe acute malnutrition in a child between 6 months to 5 years of age includes what all? So it includes what all? So it includes weight for height less than 70% of expected or less than -3 Z score. That means severe wasting, right? It does not include height for age, we know, because height for age, if it is less, it will indicate chronic malnutrition. Stunting or decrease in height for age indicates chronic malnutrition and not acute, okay? Edema, so presence of symmetric bipedal edema of nutritional origin is a criteria for diagnosis of SAM. Mid upper arm circumference less than 11.5 cm is also criteria. So our best answer out of the options given is height for age. So height for age is a decrease in height for age is an indicator of chronic malnutrition and not acute. Again, I am sure all of you must have done it correctly. Such an important topic discussed a number of times. Treatment non-responsive SAM. So this time they also asked about response to treatment. So treatment non-responsive SAM or severe acute malnutrition includes all except. So when do you say that there is no response to treatment, right? So, we have discussed in our videos what are the discharge criteria in severe acute malnutrition. Well, when will you discharge these children from hospital? So if you remember that, you can easily answer this question. So in the discharge criteria, we already discussed that, we discharge a child when his appetite is improved and he is eating well orally. So the appetite should have improved. So if the appetite is not improved, that means it is treatment failure. So appetite should have improved. What else? The child should have lost edema. The edema should have gone and the child should have started gaining weight. The child should be having weight gain. Okay. All infections and micronutrient deficiencies should have been taken care of. So infections and micronutrient deficiencies taken care of, and the mother, okay, so treated, and the mother or the caregiver is confident of taking care of child at home. So these are the discharge criteria. Okay, taking care of child at home. Okay, so coming back to our question. So treatment non-responsive, that means the child has non-responded to the treatment. That means you cannot discharge these children now. So treatment non-responsive SAM would include all except. So if there is no edema reduction by day 4, that means the child has not responded to treatment. Okay, if appetite has not increased, then also the child has not responded to treatment. Weight for height reaches -2 Z score. So this is nowhere a criteria. Weight for height reaches -2 Z score, we've seen, is not a discharge criteria. We do not see whether the child has achieved the weight for height of -2 Z score or not. Okay, from -3, whether it has reached -2 or not, we don't see. But we see that weight gain should be there. Adequate weight gain of 5 gram per kg per day by day 20 should be there. So if these three things are not there, that means edema reduction not happening, appetite not increase, and weight gain is less than 5 gram per kg per day or day 20 of treatment. So these three are indicating that there is treatment failure or treatment non-response. Okay, so the best answer out of the given options is weight for height reaches -2 Z score. So that is nowhere that nowhere indicates that the child is not responding to treatment. Okay, because the weight for height will actually take time to improve, right? So to put it in a more concise way, treatment failure in SAM, some criteria have been laid down. We say it is primary treatment failure when there is failure to regain appetite by day 4, failure to start losing edema by day 4, presence of edema on day 10, and failure to gain at least 5 gram per kg per day by day 10. That is primary failure to treatment. And what do you mean by secondary failure to respond? So secondary failure to respond means the child had initially responded to treatment, but there is failure to gain at least 5 gram per kg per day for 3 consecutive days during the rehabilitation phase. Then we say it is secondary failure to respond. Okay, so SAM remains an important topic. Now all of the following are incorrect about resuscitation of a critically sick child except. So remember the word except. So all of the following are incorrect about resuscitation of a critically sick child. So chest compression depth should be 1/3 of anteroposterior diameter of the chest. So that means if the baby is lying supine like this, how much you will do the chest compression? So if this is the anteroposterior diameter of chest, you are supposed to do 1/3 of this. So this is correct actually. Okay, this is correct. So chest compression depth should be 1/3 of anteroposterior diameter of chest is correct. Compression to ventilation ratio should be 30:2 with 2 rescuers. So in children, so in a critically sick child, the compression is to ventilation ratio should be, so if there is one rescuer, then the ratio recommended is 30:2, one rescuer, and if there are 2 rescuers, the ratio recommended is 15:2. Okay, and remember in newborns, what is the ratio? We all know in newborns what is the ratio? Chest compressions is to positive pressure ventilation. What is the ratio? It is 3:1. But here we are talking about a critically sick child. So if one rescuer, it is 30:2 and 2 rescuers 15:2. But here what is the option given? Compression to ventilation ratio should be 30:2 with 2 rescuers. That is incorrect. Injection adenosine 0.01 ml per kg IV. So, injection adenosine is not given during resuscitation of a child or in a newborn. It is injection adrenaline that is given, not adenosine. So, this is also wrong. Preferred route is intraosseous is also wrong. The preferred route is always intravenous. Only if you are not able to secure IV access, only then you give it intraosseous, right? So, the best answer out of the given options is chest compression depth should be 1/3 of the anteroposterior diameter of the chest, right? So, all of the following are incorrect except, so this is the correct option, this is not incorrect, right? Now, all of the following are true about extrahepatic biliary atresia except. So, there was one question on extrahepatic biliary atresia, right? So, the options that I got during recollection are these. The exact options, if you feel they are slightly different, please let me know, because your exact answer will depend upon the wordings of the question here. Okay, so the options are like, if the words of the options change, your answer changes. Okay, so be very careful about it. So let us go through the options. So Kasai procedure should be done within 90 days. So all of the following are true about extrahepatic biliary atresia except is the question. So Kasai procedure or the hepatic portoenterostomy should be ideally done within 60 days. Okay. So everywhere it is mentioned that it should be ideally done within 8 weeks or 2 months or 60 days and not 90 days. Even the latest edition of OPGAI also still mentions it as 60 days. So 8 weeks or 2 months or within 60 days if it is done, then it has got good prognosis, not 90 days. Okay. So this is not true, right? HIDA scan is used for diagnosis is true. HIDA scan is used for diagnosis, though it is not confirmatory. Okay. So HIDA scan is not confirmatory, but it is one of the tools that is used in the diagnosis of biliary atresia. Okay. But it is definitely not a confirmatory tool. It can be differentiated from other differential diagnosis by biopsy. Yes, so liver biopsy is a very important modality to differentiate this biliary atresia from other, disorders where you get neonatal cholestasis. This is also correct. Biliary atresia is the most common cause of neonatal cholestasis is also correct. So especially we have a lot of Western literature available. So there, biliary atresia is the most common cause of neonatal cholestasis, which has been reported in various studies. Now from India, there is a variation. Some of the studies from India also show biliary atresia as the most common cause, while some of the studies report neonatal hepatitis as the most common cause. But yes, there are studies which report biliary atresia is the most common cause of neonatal cholestasis. So if these are the options, these are the wordings of the options, then in this case I would go with, so all of the following are true about extrahepatic biliary atresia except. So if these are the wordings of the questions, I would go with A. So Kasai procedure should be ideally done not within 90 days but within 60 days. The earlier you do, the better the prognosis or outcome. Beyond 8 weeks or beyond 2 months or beyond 60 days, if you do it, the outcome is not very good. Okay, right? Again, yes, okay, very good. So I can see Ansari confirming, yes, these are the options. Thank you, Ansari, for confirming. And Dr. Sajjad has also answered correctly. Very good to see that. Okay. So which of the following is true about breast milk jaundice? So there was one question on breast milk jaundice as well. So again, a very basic topic that we've discussed a number of times in the main videos as well as rapid revision. So breast milk jaundice. Which of the following is true about breast milk jaundice? So, breast milk jaundice is due to some substances present in breast milk that can interfere with the conjugation of bilirubin and that can, that can deconjugate the conjugated bilirubin as well, right? So, if breast milk jaundice we are suspecting, then also it is recommended to continue breastfeeding. You may only temporarily withhold breast milk or breastfeeding if the bilirubin level goes beyond 20. But usually you need not stop breastfeeding, it will improve on its own. So breastfeeding should not be continued is not correct. Mostly even if you're suspecting breast milk jaundice, we continue breastfeeding, okay, and it takes care of itself. Unconjugated hyperbilirubinemia. Yes, we know breast milk jaundice is one of the causes of unconjugated hyperbilirubinemia, right? So bilirubin is either not getting conjugated properly or getting deconjugated. So this is correct. This is true about breast milk jaundice. But read through the other options also. Phototherapy is required in most cases. So most cases will be self-limited. It will not require phototherapy. a very small proportion of cases where the bilirubin levels are like very high, more than 20, might require phototherapy. But most cases, no phototherapy is required, no treatment is required. Continue breastfeeding safely. Bilirubin levels are usually more than 10 milligram per dl at 3 to 4 weeks. So bilirubin levels, so 10 at 3 to 4 weeks would be almost normal. So bilirubin levels are much more elevated than that. It can be 15, it can be even more than that. Okay, right? So breast milk jaundice, again, usually more than 10 milligram per dl is not correct. So the best option, if these are the options, the best answer, there is no doubt about unconjugated hyperbilirubinemia is going to be correct. Okay, right? The exact wordings of the other options you have to see to be very sure, but unconjugated hyperbilirubinemia, if there was an option, then there is no confusion on this. That has to be the correct answer, right? Okay, so Ajju is telling this question was multiple choice. Okay, but if you recollect the exact wordings of the options, then also please let us know, then we can revisit this question. Okay, so at what age can a child typically, so this was a question on developmental milestones, again a very basic question. I'm sure all of you must have done it correctly. So this time overall, the impression is that the INI-CET paper was usually easier than the previous than the usual INI-CET paper standard, and the pediatrics questions were also quite easy and very doable, and from the most important topics of PYQs, right? So at what age can a child typically copy a cross? So copying a cross, so this is a cross, copying a cross. So a cross has got what? 4 vertices, 1 2 3 4. So copies a cross or rectangle, we know, at 4 years, right? Tells rhymes, a child is able to tell a rhyme, a story or a song again at 4 years, and goes to washroom by themselves again by around 4 years of age, right? Okay, so tell stories also, if it is there, then also it will remain as 4 years. Okay, so the best answer out of the given options is 4 years, right? Again, a pretty straightforward question. I'm sure you must have done it correctly. Now, causative agent of croup in children. There was a question. So croup we all know is what? It is acute laryngotracheobronchitis. And it is a viral illness. We have, in detail discussed croup and acute epiglottitis so many times. So we know croup or acute LTB is a viral illness. The most common cause is the para-influenza virus. But as I came to know from most of the students, that para-influenza virus was not in the question, not in the options. So influenza virus was one of the options. Okay, Haemophilus influenzae, Streptococcus pneumoniae, Corynebacterium diphtheriae. Were these the options? So you can see all of the other are bacteria. So it is not a bacterial illness. We all know it is a viral illness. Most commonly caused by para-influenza virus, but other viruses like respiratory syncytial virus, influenza virus, even adenovirus. So other viruses can cause it, right? So influenza virus would be the best answer out of the given options if these were the options, right? If para-influenza virus was the option, then obviously that would be the best answer. Okay. Yes, Ajju is telling pediatrics mostly on basic side. Yes, no difficult questions, right? Except 1 or 2. That is very true. So the next question, a 2-year-old child presented with a history of diarrhea. Now comes with anemia. So there was a history of diarrhea in the child, and now the child has anemia, thrombocytopenia, and hematuria means some renal dysfunction. So whenever you're getting this triad of anemia, thrombocytopenia, and renal dysfunction, what should you think of? So we should think of HUS or hemolytic uremic syndrome, right? And because this is preceded by diarrhea, in this case it will become D plus HUS. Okay, D plus or HUS. And this D plus HUS is usually post-infectious, secondary to infection by Shiga toxin producing E. coli or verotoxic E. coli. The most common strain being the E. coli O157H7. So that is the most common strain which is responsible, followed by Shigella, and then Salmonella and Yersinia can also lead to it. But the best answer would be E. coli, right? The next question, there was a 2-year-old child who came with a history of epistaxis. So there was epistaxis, recurrent rectal bleeding, and bleeding from umbilicus. So whenever in any question, if you are getting bleeding from umbilical cord stump, we think of factor 13 deficiency, because factor 13 is the fibrin stabilizing factor. Okay, and if there is factor 13 deficiency, what will happen? The clot will not be formed very well. Okay, the clot will be very fragile, not very stable. So your urea solubility test would be positive, but the other parameters like platelet count, prothrombin time, APTT, all these will be normal. So in such a scenario, typically we'll think of factor 13 deficiency. Okay, so if you're getting in a child history of bleeding from umbilical cord stump, all the coagulation workup is normal like PT, APTT, platelet count, think of factor 13 deficiency. Okay, which is not a feature of cystic fibrosis. So we all know cystic fibrosis, again, almost every question we get every exam we get a question on cystic fibrosis. It is a favorite of the examiners. So we know the CFTR gene is involved. Delta F508 is the most common mutation. The chloride channels are mainly involved. Sweat chloride level is more than 60 milliequivalent per liter. So now there was a question on the clinical features of cystic fibrosis. So which is not a feature of cystic fibrosis is the question. Okay. So which is not a feature of cystic fibrosis. So bleeding diathesis, yes. Is it there in cystic fibrosis? Yes, it can be there, because what happens in cystic fibrosis, there is pancreatic exocrine deficiency. So what happens, the lipase and all are not getting secreted. So there is fat malabsorption. Okay, fat malabsorption. Because there is fat malabsorption, the fat soluble vitamins are also not getting absorbed properly. So there will be fat soluble vitamin deficiency. And which are the fat soluble vitamins? We all know they are A, D, E, K. So if they are deficient, if vitamin K is deficient, what do you get? You get vitamin K deficiency bleeding, which was previously called hemorrhagic disease of newborn. So bleeding diathesis is a feature. It can be a feature of cystic fibrosis, and we need to supplement the fat soluble vitamins in higher dose in all these patients. Meconium ileus is a feature because all the secretions, the respiratory secretions, the GI secretions are all dried up. So meconium plug can be formed, and there can be intestinal obstruction. So meconium ileus, meconium peritonitis, and distal intestinal obstruction syndrome, all that can be there in a child with cystic fibrosis. Nasal polyps and rectal prolapse are also known features of cystic fibrosis. The usual presentation, of course, is with recurrent pneumonias. So recurrent pneumonias are there, and there is fat malabsorption, so greasy bulky stool which floats on water is there. But biliary atresia is not as such a feature of cystic fibrosis, right? Okay. Yes, so as Ansari is telling, we have not, so bleeding diathesis as such we do not say as a clinical feature of cystic fibrosis, but it can happen secondary to the malabsorption, so secondary to fat soluble vitamin deficiency. So vitamin K, A, D, E, K is going to be deficient, so that can lead to it. Okay, so that is all that I could get from pediatrics. So almost 12-13 questions was there. I believe there was one more question on rotavirus. So most common cause of diarrhea in children, in a 2-year-old child with diarrhea with severe dehydration, the most common cause is rotavirus. We all know. Was there a question like this? So a couple of more questions which I got, I'll just mention. So I'm not really sure about because I could not get the exact question, so I have not mentioned it. So was there a question on most common cause of diarrhea? So Ansari Aziz is telling yes. So most common cause of diarrhea in children, so it will be rotavirus. So I believe there was a question like this. Was there a question on delayed cord clamping? I think there was a question on delayed cord clamping. Delayed cord clamping, was there a question? So delayed cord clamping, ideally it should be done in all stable term as well as preterm babies. Was there a question on delayed cord clamping? Please confirm. Yes, so Ansari Aziz says yes. So both these questions, if anyone remembers the exact question and the options, or whatever you remember about these questions and options, please mention the same so that I can add on to this list. So these were the questions that I could find from pediatrics. So I would say pretty doable, things coming from pediatrics, a very scoring subject. So there was one match the column with modes of inheritance also. That is a cross-cutting topic with pathology, genetics and all. So, and pediatrics. So that also I am sure you would have done it correctly. So these were some of the questions that I got from pediatrics. If there are any other questions, you're welcome to message me on the, social media handles of PrepLadder or my own personal media, social media handles anywhere. And, one big word of advice is, those of you who have continued to study tirelessly even after giving your NEET PG exam, and those of you who have really put in hard work to revise again and prepare again for the INI-CET exam, please guys take a well deserved break. And it is very very important to unwind and relax, because a time like this is never going to come back in your life. So finding ways to unwind and switching off is just as important as working hard. So even your mobile cannot work without recharging it, right? So please relax, unwind, recharge, spend time with your family, your friends, your loved ones. This time is never going to come back. So please enjoy and have a great time, right? And I really wish all the best to all of you for your results, and I'm sure those who have like really put on the hard work with all the determination and the belief that you can do it and you will do it and you have to do it will definitely sail through. So all the very best, my good wishes and blessings to all of you. So do let me know if there were any other questions from pediatrics, or if you feel that there are some variations in the questions. So do message me, the same, and we can discuss about what should be the best approach or the best answer. But please do take a break. Do take a break. It is very very important. Trust me. Right? So all the best, friends. Signing off. Thank you so much.